This is my third or fourth time speaking to this group, but I just find it so refreshingly radical. I think these are my people, and I feel this way every time I get back in with this group. I want to thank Jane and Jeremy for having me come back and pulling me out of speaking retirement. I first started this concept in 2002, 2003. It was a real sexy topic. The New York Times actually coined it concierge medicine, and everybody wanted to kind of lay eyes on and actually, see a living, breathing concierge physician. We were probably one of the first 50 or so around the nation, certainly one of the first in the Southeast. And, I had speaking engagements with MGMA and Pri-Med and Physicians Practice, APP, ABPS, the Concierge Society. So there were lots of opportunities. Now that this group of us has grown to 5,000 or so, I'm just kind of one of the so many, greedy, Medicare hating, self-righteous, self-serving, free market physicians just like you. So, it's really not as much fun as it historically has been in the past. Here are my objectives. I just want to talk about our last 12 to 30, another real quick comment. I'm meeting Brian here for the first time. It's really remarkable hearing his story because so much of our experience has been parallel. We started at the exact same time, one state away from each other, with the same practice name. How about that? And I didn't even learn about his practice until about 7-8 years ago, I think, when that medical economics article came out. So here I am meeting him for the first time. I want to talk about our experiences, which Brian actually kind of quite covered, so I'm going to kind of fly through a lot of these pointless slides. I want to talk a little bit about our patient demographic. Because I'm being pulled out of speaking retirement, there's going to be a lot of sort of older data, and then there's going to be some new stuff. This was an opportunity to sort of do some new patient demographic data, which was interesting to us as a practice, and hopefully won't bore you terribly, but I'm going to present some of that today and talk some about the practice management metrics, and allow some ample time for our panel discussion. So when we were first doing this in 2002 in Charleston, South Carolina, which, keeping in mind, good ideas emulate from California, of course, and then where they quickly go to New York, Chicago, through the Midwest, where they said they kind of get into North Carolina a little bit and then slowly trickle across the South Carolina border. So for us to be doing this in Charleston, South Carolina was highly radical at the time. I remember there were a lot of unusual comments about sort of what we were doing, one of which was actually opening up a practice downtown. Other family doctors were like, you can't do that. There's bridges, people don't really live there. There's just no, you're not going to be in insurance. There's no way this is going to work. And so people would kind of refer to us in strange ways, like, how's that like medical spa going? Or like, what's that like concierge medicine, or in the South, a boutique practice going looking like, So people didn't really know how to think of us. But one day in the doctor's lounge, I had this guy pull me over, like, kind of sheepishly, and be like, hey, how's that experiment going down there on Calhoun Street? He referred to our practice as an experiment. It wasn't an experiment, but maybe it was. Maybe it was an experiment. And actually, the more I thought about that, I realized we were doing a huge experiment. And here we are in the Research Triangle, having our conference here. And it occurred to me that it was an experiment, and we have 12 years of data, so I'm going to present that data to you. By the way, this picture I love, because I think it's the one that Jane got a hold of in 2002. She looked at this guy and said, look at this guy. He's not accepting Medicare or fee-for-service practice. We want to be the poster child of the AAPS. Find him and bring him to our conference, and I think that's how I actually got originally kind of introduced to this group here. All right, so here's the abstract of my experiment that we were running. It was one family practitioner prematurely burnt out from the traditional practice of medicine, but with enough remaining energy to refocus on innovative solutions in partnership with his equally frustrated patients, endeavoring to establish a new caste-based practice. And after 12 years of refining the practice model minimally, Access Healthcare has been a success by any metric and serves as a model for other retainer practices nationally. So, to create such a model, we had to find a satisfactory, successful, and sustainable model, which would be that for both physician and patient. And we had to develop a measurable, meaningful outcomes against benchmarks that define that satisfaction, success, and sustainability. And here was our working hypothesis. Just create value. Sounds really simple, right? Just create value, but value is kind of squishy in healthcare, right? We don't really actually know how to define it. And we were actually embarking on an endeavor, an experiment, if you will, to actually learn what was of value to the patient, not to the doctor. And this is, you can look at this from a supply or demand side. Certainly there were frustrated physicians, there still are, trying to find a better way, a better lifestyle, avoid burnout. But certainly there are those share of patients, and there were in 2002 when we started this, who also were not getting what they perceived as value. But we had to learn what that was, and it wasn't so straightforward. Here are our study population. This is basically the practice that I came from. 3,500 primary care patients, middle class, blue collar, small southern city, very provincial. We don't know much about boutique practices. Insurance, about 70%. Not a lot of HMO penetration, which becomes really important in the fee for non-covered service practice. So, we have a fee for covered service practice, which means that we pay our patients pay a recurring payment for everything included in our practice, similar to Josh and Brian's practice, that we don't charge anything beyond that, as opposed to the fee for non-covered service practices. These are important distinctions in that physicians will remain on Medicare and insurance panels. They'll find a little loophole in the contract, which is generally better, longer office visits, less patients, bagels in the waiting room, however they want to word it beyond the contract, and they'll charge a membership fee beyond that. But they still file for insurance, they still collect co-pays, they still have all of that going on in my world, which we refer to as concierge, boutique, retainer, direct pay. There's lots of different terms for it. We won't get into the distinctions between them. But my practice is a fee for covered service practice, similar to Josh and Brian's as well. So an HMO penetration becomes really important because HMOs can exclude you from actually ordering labs or radiology should you not be in network. And that's an important distinction. We didn't and still don't have much of that going on in my environment. Our patients were eager for change for sure. I can't tell you how many times I've heard this. I love my doctor, hate the office. For some reason, I've become a sounding board for both miserable physicians and patients. They all come to me and tell me how miserable it is out there, as though I'm like the last person to deserve that. I found a better way. Like, I don't know why they come to me and tell me that. Still, the pros of our location, we did have a very centralized area. It was visible geographically and very convenient for nearby college and tourists, so we had a lot of other advantages going for us. The disadvantages were there really aren't a lot of permanent residents in our surrounding neighborhood, very close to the office. And here was my demographics, and I like to, I think this is probably a pretty decent profile of somebody who might be successful in this model. Someone like me in 2002, perhaps, and I'll get into a little bit more of the profiling of a successful physician in this. Is someone who's I describe myself as a premature casualty of the traditional system, but listening to Lawrence's talk, which I didn't understand anything about, which I realized that I'm just missing the gene, I think, for understanding all of the opt-out provisions and the governmental sort of like line items. I mean, I listened carefully, but I honestly, I just don't, I think that's why I did this, because I didn't understand the game that I was in. And so in addition, I was certainly a premature casualty, I think, of the traditional system. Did have a strong patient following. I was in a place in life where I could delay gratification. That's important when you start any business up, and these are businesses like others, investment-minded, business-minded, of course. Josh spoke about that a little bit. Value-focused, so this concept of value, which is really kind of nebulous, but also integral to what we do. And I was certainly eager to regain some boundaries between doctors and patients. I had a certain sense of skepticism for the status quo and innovation beyond that. I remember asking the question, why in this day of internet do we actually have to have magazines that are 10 years old in our waiting room? Why not just put laptops in there at the time, and then iPads? And to this day, we don't have any paper in our practice. We just got it in the bathrooms. Actually, we put some paper in there, but we're a completely paperless office. We're just radically against paper, and that was one of the examples of that. And the sense of adventure for sure. High risk tolerance is integral. At the time, unmarried, no kids. I remember my partner pulling me aside and saying, "Wow, that's really cool what you're doing." He had 4 kids. 2 of them were heading off to college. He's like, "Can't do this now." I just met somebody who coming into the office who wanted to have a practice like this. He and his wife collectively, she was going to an anesthesiology residency, had I think $500,000 of debt. And great guy, but I don't know. I mean, you're already kind of in the hole. We need this. You're going to go further in the hole with one of these models. So I think that it was kind of an ideal time for me in my life to make this jump. and of course, a level of commitment to this, to build it and they will come, and that goes financially, professionally, emotionally, philosophically. Here's the outcome. I'll quickly just cruise you through our website, if I can do that. Kind of show you what we have. Stock photos, we've done away with that. This patient is actually not a patient of our practice. We have, similar to Brian, we have some price stratification, different plans, silver, gold, and platinum is our only price discrimination, sort of distinguishing between the plans. Again, we don't charge anything beyond that. I can drill that down for you. You can go to our website ourselves. We have 2 offices. You can have a quick look inside our office. We take a lot of pride in how the office appears, making sure that it doesn't at all resemble a traditional practice, and we get all kinds of compliments by people walking into the office. It is an amazing place, but if they compliment us too much, we got to look them up on the prescription database because they typically end up being drug seekers. There's a couple of other criteria for that: driving more than 35 miles an hour down the driveway, Friday afternoon visits, and a referral from the phone book where we haven't been in for 10 years. So we have a whole sort of profile of the average drug seeking patient, but they really, really love our office, and me, it's like something it's not that great of a place. But so a quick look inside. We tried to kind of hang on to sort of some of the remnants of the past. Things like exam tables really haven't changed in the last 125 years. And so we have a healthy respect for the history. We're in downtown Charleston. It's a 125-year-old house. So you get a kind of quick feel. So here's some of the outcomes from our experiment here. Just some patient demographics. This is old data. It's 10 years old, but I don't think that this has changed much. I don't know if you can read this, but while the mean income in Charleston was $37,000, you can see we have about a quarter of each of these brackets, less than 50,000, between 50 and 100, 100 and 200, and greater than 200. So there's clearly a higher socioeconomic status of our patients. But like Brian mentioned, we have had that scenario in our waiting room not uncommonly as well. Here's the breakdown in terms of employment status. 60% working roughly, 10% college because we're in a college environment, 10% dependent, and 16% retired. And then the 7% non-working category, which apologize if there are any non-working people in the room here, but there's a certain diagnosis, I don't know what it is, between people that don't work and also have a lot of money tend to be some of our higher utilizers in our practice. I'm wanting to study that at some point. We did a cool experiment about 10 years ago. We tried to identify why patients or what they were perceiving in value. This is to the point of value perception. We wanted to know who they were, and so we made these 4 buckets, and we surveyed our patients. Those were valued seekers. We asked the question, I'm uninsured, I have a high deductible, so my medical practice has to be a cost-effective solution. Inertia enablers, those are people who just want to kind of follow me. They didn't really understand this like new practice style, but they just thought I was cool, or they just didn't want to go through the pain or suffering going to a new doctor. Financially unconcerned, they saw this as premium gasoline, regardless of what we actually were doing. They thought this was kind of cool. And then there were the worried well and medical misfits we described as hypervigilant. So what we did was we went through our entire patient population, this was 10 years ago, and put people in those 5 buckets. And then we surveyed our patients with these questions and asked them where they felt they were seeing the value. What was interesting was that there was no correlation at all. Therefore, we used our data because we knew who they were better than they knew who they were. So we sort of, but what's really interesting, like for example, the financially unconcerned are 36% by our assessment and 0% by the assessment of the patients here. So you can see the other categories really don't correlate at all. So this exercise is probably pointless. But worth doing, I think. I mean, probably for your practice as well. Here's a utilization curve. I think that that was Brian got into this a little bit in terms of the question always comes up. Well, don't you have those people who are unemployed and have a lot of money who bother you a lot, like in the middle of the night? And certainly we do, and it's about 6%. The same percentage, by the way, I'm just noticing now, as our unemployed population. So I wonder if they're the same patients. Patient satisfaction surveys we just read recently, that what distinguishes a good practice regardless of traditional practice from that's not so good is whether you survey their patients and what frequency they survey their patients. We did this 10 years ago and haven't done it since. Our patients like us. Either that or they're just afraid that we'll know who they are when they fill out the survey because we have such a small practice. But obviously, I'm presenting that data. So here are our numbers. This actually correlates exactly with what Brian was describing. 35 patients a day in a traditional practice. We have 10 to 12. FTEs about 6, which is heavy in the former practice. We now have 1.5 FTEs per practice in our two-doctor practice. Where I've only remembered about 90% of my staff, and in any given day when I walked into my office, I now know 100% of my staff's names when I show up to work in the morning. Minimal IT investment. We take a tremendous amount of pride in our IT. It's the only other thing I'm really passionate about in medicine really is what we're talking about right now, and a paperless office. And so lots of dictation costs, which we don't have any longer. And there is a significant startup expense, as there should be for any new endeavor. Here's some other age demographics, not terribly interesting to you, but we thought it was pretty cool. The thing I'm interested in, so our average age is a little bit younger because we are in a college town. What's interesting here is the median age is, simulates my age, which I'm sure that's true of any practice, right? You grow old with your patients kind of thing, probably terribly uninteresting data there. But we did want to study it. Insurance status, also not terribly interesting. Of note, in 2005, we had 8% Medicare, 16% now, versus 31% MGMA, current data. That also is not terribly interesting. That's probably an aging of me and my patients as well. We have about 73% currently private pay patients, which is greater than MGMA, of course. And of note, and Brian brought this up as well, our self-pay population of about 8% in here, which is shockingly low. One other point was that our design was actually not the uninsured when we were getting started. We thought we were going to appeal to the high deductible HSA population, so we tried to distinguish between them back here, when now it's virtually impossible. I don't think patients even really kind of know what that means or where's the cutoff. If you ask them if they have high deductible, they get, they look at you kind of fuzzy. They don't know what you're talking about. And here's a referral basis where our patients come from. Anybody who runs a practice like this will tell you that it's primarily word of mouth. There's lots of great ways to waste money to get patients in this model. I have a lot more to say on that if anybody has any questions about marketing. This is an interesting question that comes up from time to time. If patients pay you, do they kind of expect you to deliver what they expect? And it really is kind of an interesting ethical question. I won't get into any of the ethics now, but I became interested in this because I was finding myself writing more controlled substances. I get into a lot of testosterone therapy, and these numbers reflect that. But benzos, opiates, not to mention the antibiotics. But I think that these numbers, I couldn't find any numbers from a traditional practice, are scary to me, and I think they represent not necessarily a purchasing of your doctor behavior, so much as what's going on in primary care over time in general, in that patients are finding that primary care maybe only has a role these days, considering the pain and suffering that typically goes into seeing a primary care doctor, to prescribe controlled meds. And I mean, that's a kind of a big statement. Maybe it's defensive for this number here, which I am not proud of, but came out of our data collection that half of our patients are on at least one controlled substance. Here's some financial outcome measures for our practice. This is an investment over time. We didn't draw this back, but yeah, there was at least a year without any salary at all, and now we're close to. I'm happy to show these numbers transparently. I think it's part of the talk. People ask the question anyway, and they want to know. So my annual salary is coming close to about $300,000 a year. There are many other sort of numbers that are not in there, but that's just the gross salary. Here's some attrition numbers, and a lot of the guys that do this elsewhere say that their practices are full, they're on wait lists, they never lose patients. I don't believe them. We're in a demographic where there's a lot of turnover. We get patients that come to us in unusual ways. We have a lot of college students, a lot of transients, so we have a lot more attrition. So we lose about almost as many patients as we gain a year. Our practice is growing for sure, but we lose almost 70 patients a year, which is a lot of turnover. And again, speaks more, I think, of our demographic. But the average length of time that those patients stay with us is, in quarters, is between a year and a half and 2 years as they leave. There is some really old data here, which I won't really go into, but this is actually the most current data of a retainer medicine practice from 2004. This guy, John Dean, somehow I don't even know how he got it. met him in a conference at one point, and he really didn't kind of go into it. But here's our comparative data, which actually was not far off from some of these numbers here, and I don't really have time to go into that. I'm coming close to the end here. So here are the intangibles, which is where I think this is really at. So I'll just read through this real quick. Physician disposition, where in my former practice I was having increasing irritability. I'm now described as being less irritable by children, pets, drug reps, significant others. Some untoward physician behaviors, which I know you don't experience in your practice, but I found myself like kicking my desk a lot, like formerly, and now I still kick it, but it's those 7% of the patients that have me doing that. A lot less desk kicking now. Not as much passive aggressive tardiness. I'm now on time. Where my blood pressure had been rising before, and now I'm finding myself normotensive. You'll be happy to know. Where there was no job security because we were working for the hospital, and then we were working for ourselves, and then we didn't know whether we were going to make it. Now I have full ownership of our practice and my destiny. Weekly hours are about the same. The flexibility, where there was no flexibility, I now have theoretical flexibility, which means that like I can take off here today, but as soon as I get out of here, I'm going to be answering a whole bunch of texts and emails, I'm sure. So, but it is a more flexible lifestyle. Where I would just be triaging by telephone, I'm now 24/7, and that means that I do go into the office after hours and on weekends. My malpractice threat was covered by Brian as well, where that is most definitely tenuous as a function of our overall volume and quantity of patients. It's now described as contained because we have better relationships. I only have 384 patients. It's a whole different game. Recurrent dreams of men in suits calling on lines of credits. It was horrible. Now I dream of promoting retainer medicine practices nationally. My doctor-physician relationships were suffering for sure towards the end, and now I describe this as a reestablishment of those relationships. Where I became the sort of master of apology and had mastered the art of interruption, I now am really focused on patient care. And where I would be dictating 2 hours a day, and now it's point of care technology. The work is really done when I walk out of the room, and that's really kind of a wonderful thing. If you haven't experienced it, I mean, it's just great to be done when you click sign. The workflow environment was described as chaotic and with entropy, and now I have order and accountability in my workplace. My prevailing psychological disturbances in the past were described as a constant sort of chronic underlying smoldering feeling of inadequacy that I felt as a physician in my former life. That hasn't changed for some reason. I don't know why. I mean, I have like 5 to 10% of the patient volume that I had before, and I think that problem hasn't gotten any better. I don't understand how that is. And this is probably the best intangible here. I've taken 20 seconds off my 2 mile in the last 10 years, and that's my commute has gone from 5 miles dictating in the car to 17 leisurely steps from my apartment upstairs, which is, I still come late sometimes. I don't know how I can. All right, here are the limitations of this study that may not apply to you. Is there's operator variability. Your experience may differ. Certainly, geographic is big. Demographic is big. The timing, of course, is integral when you do this in your life. And in conclusion, I feel that from our experiment that we did here, a 12-year experiment now, the retainer medicine practice is a viable, sustainable practice model in the right environment and with the right execution. I feel like it's a financially risky but sacrificial and hard endeavor. And a retainer practice is comparable to traditional practice financially, but has the intangible and unquantifiable benefits of authenticity, of ownership, improved relationships, quality of life, autonomy, and sustainability. Thank you.